Hi, good morning. I'm Dr. Shah, Associate Dean of Global Health at Des Moines University. I'm a geriatrician, do memory clinic at Des Moines University Memory Clinic. I'd like to thank iShare and its staff for organizing this program for us. Let me start with this saying that we all anticipate the loss of certain things in the process of cancer treatment. Hair comes to mind for the right away. But losing one's mental age is often unanticipated. And that's what I like to talk about in next 45 to 50 minutes. I just want to disclose that I don't have anything to disclose, and the statement is over here for you to read. So what I'd like to talk would be to talk about what is chemo brain, and how does our surgery anesthesia affects our brain. But before I do that, I'd like to talk about and be all of us on the same page as far as what is dementia, what are the reversible causes of dementia, and then if we get chance, also talk about how to evaluate memory and how to improve one's memory. So those the starting point. Let's start with the case. And you can change the name and details about the case, but I'm sure many of us have come across something similar. Linda is a 67-year-old white female. She is very healthy except for mild hypertension. She was recently diagnosed with invasive ductal carcinoma, one of the common form of breast cancer. And for that, she received chemotherapy. Post-therapy, she started finding that she had difficulty word finding, she had problem solving difficulty, and she was very active prior to this detection of breast cancer, but found that she had very hard time doing multitasking. So the question to us, to me, and to our group is, what's this condition? How long will it last? Her concern, her relatives' concern is, can this condition, would it lead into disease called Alzheimer's? And of course, her other concern was, what can she do now and in future to prevent things, what's affecting her memory. So as we go through this next 1 hour, I'll take you through this process. We'll come back to the case and see what's the diagnosis. But before we do that, let's come and common terms. So the old term many of us know as dementia, which is the broad umbrella term, meaning loss of memory with one other functional loss. Either it might be language, judgment, or executive function. This is according to DSM-4, the Diagnostic and Statistical Manual 4, which is the older way we defined and classified our psychiatric illnesses. So for that, the dementia came as a memory loss with one other functional loss. And this is the important part, that has to be enough, the memory loss has to be enough that it affects person's social or occupational life. So that's according to DSM-4. There was a new way to classify psychiatric illnesses under the DSM-5, which was released last year after a lot of debates and discussion. And according to DSM-5, dementia is now considered as a neurocognitive disorder. And dementia is a major, divided into two major parts, major neurocognitive disorder and mild neurocognitive disorder. A major, of course, has Alzheimer's and other forms. So those terms have remained the same. And the mild as the mild cognitive impairment. So let me quickly define what they are according to the new definition. According to DSM-5, dementia now is substantial cognitive decline. So we're not talking about just memory, not just the language or the executive function, but overall cognitive decline enough that it interferes with person's independence. And this is a major neurocognitive disorder. The mild version would have not sufficient decline, and so the person can still remain independent. So with those two types, you might wonder where does the Alzheimer's fit in. The Alzheimer's, which is the most common form of dementia, fits into the non-reversible form of dementia, and there are many other non-reversible dementias, vascular, frontotemporal, Lewy body being some of them. Unfortunately, 95 to 97% of all dementias come into this category of non-reversible dementias, and Alzheimer's being the most common one. So many times you might hear term dementia and Alzheimer's interchangeable, both in literature or in normal communication, and that's fine. Even because they are common, Alzheimer's being common, almost 60% of all dementias are the Alzheimer's type. So that's okay to interchange occasionally, but to keep in mind that there are many other types of dementias also there. So that's the non-reversible part. Then to give you the risk factors, I feel this will help us to know and understand the chemo brain better. So the risk factors for all non-reversible, especially the Alzheimer's, are well established, and the established one are our age, the family history. If somebody has history of Down syndrome, the chances of that person having dementia once that person lives long, and if it's very high. There's a gene called ApoE4, and especially in Caucasian, in the white population, if there are two alleles, ApoE4, E4 twice, that person has higher chance of dementia. And this atrial fibrillation diagnosis is relatively new, that if somebody has new onset of AFib with later age, there's a higher chance of getting dementia. So these are well established. And then there's a huge new research, a lot of new research on what are possible lifestyle factors which might affect somebody's memory, cause dementia as we age. And a lot of things have come under that: physical activity, social interaction, head trauma, as you might have heard during our NFL players and boxers and soccer players, and lots of health conditions. The chronic conditions like stroke, hypertension, diabetes, hyperlipidemia, obesity, depression, sleep apnea. So the reason I mention all this is that as we talk about chemo brain, you can keep some of this in mind, that if our patient with cancer, with chemotherapy, like Linda, she already has hypertension. Now that already has increased chance of memory loss, and on top of that, we add chemotherapy. So these are the factors which are towards the non-reversible forms of dementia like Alzheimer's disease. What are the reversible dementias? They're unluckily only less than around 2%, maybe maximum less than 5% of all dementias are reversible, that we can do something and that will change right away. And that forms with the mnemonic called dementia. So let me not to go through each one of them, but get you the list of the dementias which are reversible are under the mnemonic of dementia, like drugs as the first one, that lots of drugs which can cause us to forget, which if we once stopped, hopefully that memory will come back. Depression is one of the major cause in elderly as a reversible cause, that if depression is identified, treated successfully, hopefully the memory will come back better also. And then there are many others, hypo and hypernatremia, meaning sodium being high or low, the calcium being high or low, glucose being high or low, thyroid, hypo and hyperthyroid, and many other conditions as mentioned over here. So let me talk about drugs here, and you'll see and listen to me and come up back with the drugs multiple times, because I feel drugs in elderly and drugs in memory have a lot in common. So when I say drugs, meaning all medications, both prescription and over the counter, that three things our patients can do, two or three things we can do. We need to reconcile our patients' medications, meaning if they come to hospitals from nursing home, we need to check whether the medicines what they were taking in nursing home is it same as what we are giving in the hospital. When they are discharged from the hospital to home or nursing home, we need to again check whether whatever medications we are giving them in the hospital, are they going to be taking home or not. So medications are extremely important, both for cause of our chemo brain as well as for all the medications cause related with dementia. The long list of medication, I'm not going to go through each one now, but give you the idea that many medications have direct or indirectly effect on our memory. And as you can see the list, they all tend to form into a group called anticholinergics, meaning they affect our level of choline in our brain. We all need acetylcholine, a type of neurotransmitter in our brain to form and to keep our memories. And the medications, whether it's a sleeping like Benadryl or pills for pain or anti-anxiety, the tendency some of them have is to take away this acetylcholine which we need for our memory formation. And the other problem is that these drugs have a cumulative effect on our brain, meaning if one has mild anticholinergic property put together, if I'm taking 3 or 5 of these drugs, they tend to even accumulate in my brain and cause more anticholinergic properties. So keep that in mind as we go through today's talk and as you see your patients with possible memory loss. This group of drugs will come across again and again. So let's now come to our topic of chemo brain. What I'd like to cover in this subtopic is what is chemo brain, how common is it, what are the outcomes if it happens, what to expect, what are the potential causes, and then other important topic I'd like to talk about in that would be what is post-operative cognitive decline or POCD, that what happens to us, young and old, healthy or not, after we go through major surgery and anesthesia. So that's the coverage for the next part of our talk. So what is chemo brain? Known by different terms, chemo brain or chemo fog. Basically what happens, it's a form of memory loss, luckily mild form, mild cognitive impairment, which means that people have enough cognitive decline, as we talked earlier, but they can still function independently. The other thing, the reason I want to talk about post-operative cognitive decline is that even though it's called chemo brain, that's not the only cause of it. There are multiple causes which might affect patients after their chemotherapy. So how common, when you see in any studies, when you see the percentage varying so much, 15 to 80%, that means we don't know how common it is. It's probably very common, but the problem it is not hard to know is that almost one third of our patients who receive chemotherapy, they might have some form of cognitive decline even before they start their chemotherapy. So that's one problem. Second problem is with age, many of us tend to neglect early changes of dementia or memory loss and just assign that to aging. And that's why it's hard to know. But irrespectively, it's common. And the common thing is that people tend to find difficulty with just words or names, or might just say, hey, it's a tip of my tongue, but can't bring it out. Luckily, almost two-thirds of 60% of them will get better with time, within 3 to 9 months. Like many things, it's never fast enough when the patients want to feel better, but they get better. And about one third of them tend to remain with that diagnosis of mild cognitive impairment or MCI, which sometimes can become long-term Alzheimer's disease. We'll talk about. So that's the common and outcome of chemo brain. That it's common, very common, and many of them get better, not all. What are the causes? Long list of causes according to literature. As we talked about different forms of dementia with its causes, the chemo brain cancer itself can cause it. If the cancer is in the brain, especially the area which has the memory parts, the hippocampus, then it can cause chemo brain. The medication itself, the chemotherapy, the medications given along with chemotherapy like steroids, nausea, pain medicine, sleeping medicines, they all can cause. If somebody has to have surgery along with chemotherapy, as we talked, and I'll mention more about the post-operative cognitive decline, that itself can cause that. Chemotherapy, anxiety, surgery can affect person's sleep, and there are direct relation between sleep problems and sleep-associated memory decline, and many others like depression and anxiety. So let's talk about few of them, and especially focus on the post-operative cognitive decline. I feel, being in the field of geriatrics for more than 20 years and having done pre-operative and post-operative evaluation of many patients, I feel this is an area which is not discussed much by surgeons. Patients are not informed appropriately about what will happen after the surgery, and they suffer more. So post-operative decline can be defined into two bigger terms. One is cognitive dysfunction, just like the chemo fog or chemo brain. And the immediate big one, which many of us see, especially in the hospital and maybe in nursing home, is post-operative delirium. Delirium, just many of you know, but to just bring back on our same page again, is acute confusional state where attention and cognition are affected. So it's a state which comes suddenly, affects person's cognition and attention. And other factors are, for appropriate diagnosis, has to be that it affects our cognition. It fluctuates a lot, meaning if I see the patient at 7 in the morning during my rounds in the hospital, patient might be clear, but right away at 8 o'clock, if a nurse goes to give medicine, she might find the patient is confused. So that's the difference, that it fluctuates a lot, unlike dementia. Dementia doesn't fluctuate as much as delirium does. The important part for delirium is that delirium is the one which is usually caused by medical condition, and it's usually reversible, unlike dementia, which is most of the time non-reversible. So like we talked about dementia with a mnemonic of dementia, there's a mnemonic for delirium, which is over here. And again, as you can see, drugs are the first part. That drugs, especially multiple new drugs in the hospital setting for patients with chemotherapy or without chemotherapy, tend to cause acute confusion or delirium. And the rest of the mnemonic are over here to go through quickly, are the electrolyte change, taking away the drugs patient might be used to, especially drugs which they might be dependent on, like sleeping pills or anxiety pills, infection, urinary tract infection, lung infection, and something again in the brain, not very common, but something to keep in mind. So drugs If there was one take-home message for you during this talk, one of them would be that polypharmacy, the drugs affecting our patients, patients' memory, patients causing chemo brain, and causing confusion. So similar list, which we went through for dementia, reversible dementia, also can cause acute confusion or delirium. It's many times it's difficult to compare and difficult to distinguish dementia and delirium. So to recap, delirium, which is acute, usually there's inattention, and it's reversible. While dementia, whether it's Alzheimer's or other form, the patients are usually alert. The level of consciousness, LOC, the level of consciousness, they are alert. They tend to be chronic, meaning over weeks or months or sometimes years. And there's a loss of memory, while usually they are irreversible. The dementias are usually irreversible. So let me now come to another part of our discussion, which is the cognitive assessment. That if we see a patient, like in our case, Linda, if we see a patient with possible mild cognitive impairment, what are the ways to distinguish and what are the ways to assess the patient? So before I give you the way I do, let me again remind you what are some of the red flags, what are some of the things which you might want to see, either if you're taking care of them as outpatient, inpatient, nursing home. The patients will tend to repeat if there's mild cognitive impairment. Repetition is more than usual. Within 7-10 minute conversation, most of us don't repeat the question unless if I'm talking to my mother-in-law, that's a different story. But apart from that, usually there's they tend to, if they are with their caregiver, they tend to, instead of answer directly, they tend to defer to their family members. And sometimes they might come to you on their own that since receiving this chemotherapy, I feel my memory is lost, I feel my capacity to do multitasking has reduced, or the names which were coming quite quick to me are not. So they might come to you. The other thing about memory loss is that sometimes there are some benefits of having the memory loss. You never have to watch the returns on the TV. You always are meeting new people. You don't have to remember wines of your spouse if you have a spouse, and you can hide your own Easter eggs. So with that, how do I evaluate? I take thorough history from the patient and caregiver. They both have to be there. We take history, the exam, and of course the blood work, appropriate blood work, which you might have heard during the other dementia talks. The other forms, which are multiple available, some are free online, some are not. Mini mental state form I mention here, mainly because it's one of the most commonly discussed way to evaluate memory. What I have found with mild cognitive impairment with chemo brain is that usually people are not declined enough, and mini mental state exam form is not sensitive enough to pick up early changes. So I don't use the mini mental for mild cognitive impairment in our chemo brain, but here to show you that it's available, people use it. The other test used is called clock draw. Again, not sensitive for early changes, but commonly used so over here. The form I like, which is available online, it's called MOCA, Montreal Cognitive Assessment Form. Shown over here, available in multiple languages, available in different forms, and I feel as an office procedure, it's easy to perform, takes about 7 to 10 minutes, and gets easier once you've done enough. And it's sensitive to pick up early changes, including mild cognitive impairment. So if you have not used it, do download the form. Again, as I mentioned, available in many different languages and available with instructions. So that's what I use for my patients with. And as I mentioned, most patients with chemotherapy, without chemotherapy, when they have depression, memory tends to be affected also. So I do check for depression using this form. You can use geriatric depression scale. There are many other forms available, and depending on the age of the patient, you might want to use PHQ-9 or this GDS or geriatric depression scale. And I do check on that first and prove that patients either have depression and treat it, or that the depression is not available. So that's the form for depression and the previous form for memory loss. So once we detect that using the MOCA form, and if you find out the patient does have mild cognitive impairment and there is some relation to chemo brain, then next question that your patients will have is, what can they do? What can they do to prevent further decline, and what can they, he or she can do to protect what's going on? So what I would suggest is, first would be that if they are in the acute setting, and if they went through delirium or acute confusion, well-proven simple measures, even though this is an old study, came from 1999, still worth using some of these four simple steps in acute and nursing home settings. That appropriate sleep. If patient is able to get up, they should be asked to walk around in the hospital setting as early as possible by removing their tubes, their catheters, their Foley catheter. If they have visual or hearing aids, then that should be used during their acute setting. And especially applies to during summer, applies to our elderly patients, that if they have any form of dehydration, then they should be treated for dehydration before we treat them for other things. So these are the four well-proven simple things for prevention of dementia and delirium, But what other things our patient who has a mild cognitive impairment and otherwise not significant past, no history of delirium, what can this person do? So these are the four well-proven methods to prevent acute confusion in our hospital setting or nursing home setting. And let's now talk about our patient, the patient who's come back with possible chemo brain or chemo fog, that the memory is affected, but not enough to interfere with the independence, but mainly cause mild cognitive impairment, that where that she, in our case, doesn't feel that her names, what friends' names and her colleagues' names are coming smoothly, that there's tendency to forget and repeat few things. So four well-proven things in the lifestyle modifications are regular exercise, both physical and brain exercise or cognitive exercise, diet, the right amount of diet and right type of diet. We'll talk some of the examples. Social interactions, which helps both with depression, isolation, and with early memory changes. And as you might have expected, managing our medications. That many medications, both prescription and over-the-counter, has significant role to play in keeping our memory intact. So let's go through each pillar and see what we can advocate and tell our patients with possible mild chemo brain or mild cognitive impairment. Exercise, simple physical activity, moving more, has proven multiple times, multiple studies have shown that whether it's a simple walk or jogging or anything which uses the, the big muscles, biking, swimming, skiing, has all been very helpful. And the reason there is a significant connection. The reason there is a growth hormone in our brain, just like growth hormone for our body. And the growth hormone is called D as in doctor, BDNF, brain-derived neurotropic factor. That as we exercise, when we exercise, there is a release of this hormone BDNF, which then helps to form new brain cells and new synapses or new connections, neurogenesis and synaptogenesis. Again, using our brain for exercise, old saying is true, use it or lose it. And just like aerobics for the heart, for the brain it's called neurobics. That anything which we can do to challenge our brain, learn something new, will help to form new memories, new brain cells, new synapses. And it's not about getting the right answer, it's about the search which has been more beneficial. And there are again many different ways. We don't need to use one particular model. We can tell our patients whatever they feel they would enjoy as a hobby or they might have done in the past, they can do it now, which will help to improve their memory. There are multiple things, many studies that have been done, whether it's a book club or playing Go or chess, listening to new music, whatever might work. The second pillar for potential prevention or potential treatment of mild cognitive impairment is appropriate diet. There are many diets, many food samples are known as smart foods. It can be combination of them. There are types of diet, one in particular called the Mediterranean diet you might have heard about, which is mainly used in the Mediterranean region, the southern France, Italy, Spain, which is based on fish, olive oil, fruits and vegetables, and less emphasis on meat, and that's been shown to be very helpful also. And here are some of the examples of the food from the smart food. For the diet, I would not suggest significant change to make, but just add some of these factors which are helpful. The third pillar for our brain health, for cognitive health, is social interaction. Many studies have shown that social isolation causing depression, anxiety, memory loss, and in few cases the early death, while long-term connectivity has helped to show people live longer. And these have come up in studies called blue zones from different parts of the world. So connectivity would help. And the last one would be the medications. As we have gone through, that medications, appropriate use of medications, reconciliation of medications will help. So let's go through our case again, what we started out, and then see how and what we can suggest to our patient. So our case, as you might recall, a 67-year-old white female with hypertension and ductal carcinoma, for which she got chemotherapy. And post-therapy, she potentially developed chemo brain or chemo fog, where she had difficulty with focusing, with word finding, and unable to do multitasking. So she went through appropriate diagnosis, went through, let's say, MOCA, and her diagnosis came as mild cognitive impairment, very likely related to her chemotherapy recently. She's still able to function independently, drive, and take care of herself and her family. So hopes, what would I tell her if she's in my office today? I would say that luckily this is mild cognitive impairment. Very likely it will either reverse or get better over next 3 to 9 months. that meanwhile she would manage and do and focus on the 4 pillars of the healthy brain we talked about. If she's not exercising, I would regularly ask her to exercise, walk, simple walk, for at least 5 days a week, 20 minutes, do some brain exercises. Recently, weights, lifting just simple weights have shown to be helpful. So I would suggest that as adding some weight lifting as part of her healthy diet. We talked about, if I'll go through her nutritional history and see if she's not eating any of the healthy food, the smart food, we would talk to about that, refer her to a nutritionist. Talk about her social life, see how well connected she is, and if she's not, that might be something to focus about. And definitely, before all this happens, I would go through her medications and see if any medication is strongly anticholinergic, which I can change, remove, slowly taper off, and add anything which she might need towards her health in the form of fish oil, if she can't get enough fish, B12 and others. So, and I can then tell her that very likely, if we can do all that, this will get better. I'll recheck her memory in the form of MOCA, Montreal Cognitive Assessment, after about 3 months and see whether that's got improved or not. So with that, I'll end here. But as I mentioned, to summarize, the chemo brain or chemo fog is quite commonly missed, because we as clinicians have not been able to tell our patients what to expect as far as memory goes after chemotherapy. But easy to diagnose, and once diagnosed, there are now multiple evidence-based ways patients can change their lifestyle enough to get better and keep their cognitive function before and prior to receiving chemotherapy or prior to receiving their surgery. I do have a lot of references for you. They are both online and hard copy. Feel free to look at some of them. They all will be helpful towards the patient and patient care. With that, I'll end here. Thank you.